Hello, and welcome to the Performing Exposure Calculations webinar. This is part of ATSDR's Public Health Assessment Webinars training series. This webinar is sponsored by the Agency for Toxic Substances and Disease Registry, called ATSDR. The content covered in this webinar is based on the second part of Module 7 in ATSDR's online Public Health Assessment Training, or FAT. For reference, you can find the presentation slides I'll be using and the recording of this webinar on ATSDR's website. The files are available in accessible format for people with disabilities. Thanks so much for taking the time to attend this webinar. My name is Karen Scruton, and I am the Section Chief of the Exposure Investigation Section at the Office of Community Health Hazard Assessment in ATSDR. I have extensive experience in conducting public health assessments using ATSDR methodology, including quantitative assessment of potential impacts to human health resulting from exposure to contaminants in environmental media, like drinking water, soil, and air. Let's talk about our topic for today's webinar. It is based on Module 7 from the FAT module called the Health Effects Evaluation. FAT Module 7 taught you how to perform various steps of the Health Effects Evaluation. Our webinar today will focus on performing dose calculations from ingestion of contaminated media like water or soil, and determining air concentrations for evaluating inhalation exposures. In addition, we will go over how to calculate hazard quotients and cancer risks. During today's webinar, you will learn how to do the following. Evaluate quantitatively the contaminants that met and exceeded the comparison values, or CVs, in Module 6. Calculate exposure doses for ingestion and dermal contact. Derive hazard quotients, or HQs, to evaluate non-cancer hazards. Calculate cancer risk, or CR, for carcinogenic contaminants. Evaluate exposure to contaminants in air. Note that this differs slightly from the evaluation of contaminants in other media, such as soil and water. And use ATSDR's Public Health Assessment Site tool, called FAST, to evaluate default and site-specific exposure scenarios. You're probably familiar with this schematic on the steps of the public health evaluation process from other training modules and webinars. As shown in this slide, the public health evaluation process has many steps. These include the following. Identify exposure pathways, define exposure units, compile data for each pathway, identify potential contaminants of concern, often called potential COCs, through a screening analysis, estimate exposure point concentrations, called EPCs for short, use ATSDR's FAST to calculate doses, adjusted EPCs for air, hazard quotients, and cancer risks. Evaluate contaminants further by conducting an in-depth toxicological evaluation when an HQ exceeds 1 or a cancer risk exceeds 1 × 10⁻⁶. Summarize the health effects findings, including discussing uncertainty. The topics in this diagram that we will cover in this webinar are indicated by the circle and the middle box. We will talk about using FAST to calculate doses, adjusted EPCs for air, HQs, and cancer risks. Later in this webinar, we'll have a short demonstration to show you how FAST works. I will only provide an overview of FAST, but there are numerous training videos available on the FAST resources page that provide more detail on how the different parts of FAST work. In the previous FAT Module 6, we discussed how potential contaminants of concern, or potential COCs for short, were identified that will need to be evaluated further in the health effects evaluation. The potential COCs were primarily identified for the following three reasons. First, the primary way we identify potential COCs is because the maximum concentration in a given medium met or exceeded screening levels, which include ATSDR CVs or non-ATSDR screening levels. The webinar on data screening analysis in this series covers our screening process to select potential COCs. Second, a potential COC may be identified because appropriate screening levels aren't available. In these cases, we retain these contaminants for further evaluation. And third, we may learn that a community is concerned about a contaminant, so we label it as a potential COC and investigate it. The purpose of the health effects evaluation is to closely examine potential COCs for each completed and potential exposure pathway and duration of interest. During the process, we use default or site-specific factors to determine whether harmful effects might be possible and whether public health actions are needed. This slide provides information on the terminology we'll be using in this webinar. We will define each term as we go along. I want to mention that we have a webinar in our series called Estimating EPCs and Defining Exposure Units, which covers the first two topics listed on this slide extensively. So I won't be discussing them any further, other than to say that the EPC is an important value used to estimate exposure doses and subsequently to determine health effects. We will be discussing the other terms on this slide as we go through the webinar. The overall steps in the health effects evaluation process are on this slide. This presentation will provide information on how to derive exposure doses for oral and dermal exposure using the EPC and default and/or site-specific intake factors. The exposure scenario chosen may include a central tendency exposure, called the CTE, which is a typical exposure scenario, or a reasonable maximum exposure, or RME, which is the value on the high end of the exposure distribution. It will also provide information on how to derive dermal exposure doses from contact with soil and from contact with water. For inhalation exposure, we have a different approach and do not calculate doses. We identify the concentration in air that will serve as the EPC and adjust the air EPC to account for the duration, frequency, and time of exposure. The resulting adjusted EPC is then compared to inhalation health guidelines. The adjusted EPC is also used to estimate cancer risk. We won't have time to cover the inhalation approach today, but you can refer to ATSDR's Public Health Assessment Guidance Manual, called FAGM, accessed through ATSDR's website for more details. We will also discuss how hazard quotients, or HQs, are derived for oral, dermal, and inhalation exposure using appropriate health guidelines, such as ATSDR's minimal risk levels, called MRLs, and EPA's reference doses, called RFDs, and reference concentrations, called RFCs. These health guidelines are used to evaluate non-cancer endpoints. Cancer risks are derived to evaluate carcinogenic contaminants using EPA's cancer risk values, including oral cancer slope factors, called CSFs, and inhalation unit risks, called IURs. Finally, both the screening and health effects evaluation should be done within FAST. FAST provides a consistent and reliable screening and evaluation of health effects using the most up-to-date information. So what is FAST? As I mentioned, FAST stands for the Public Health Assessment Site Tool. The image on the right of this slide is the FAST home screen, and we will go through FAST together in just a bit. ATSDR developed FAST to screen contaminants and to calculate exposure doses and adjust EPCs for air in order to generate age-specific HQs and cancer risks. FAST has a resource page that includes ATSDR exposure dose guidance, or EDGs, documents that provide the basis for the methods and input parameters used in FAST. In addition, the most up-to-date CVs, health guidelines, and cancer risk values are stored within the FAST database. The output from FAST should be used in your public health documents, such as public health assessments, also known as PHAs, and health consultations, because FAST provides quantitative results that are consistent with ATSDR policy and guidance. FAST is an internal web-based application, and ATSDR grants access to approved users. Individuals who are involved in ATSDR's PHA process can request access to FAST by emailing fast@cdc.gov. So let's start at the beginning of the quantitative health effects evaluation with exposure doses. Exposure doses are calculated estimates of the amount of a contaminant a person might contact in the environment per unit of body weight and time. ATSDR uses pathway-specific equations to calculate doses. For the default scenario, 2 doses are derived. As we just talked about, the RME dose represents the high end of the exposure distribution, and the CTE dose represents an average exposure. So let's look at the general equation for deriving an exposure dose. D represents exposure dosed, which FAST will be calculating. The other letters in the equation are the exposure parameters, also called input parameters. These vary by medium, age, and exposure scenario. The parameters used to derive age-specific doses will reflect the CTE and RME scenarios we just talked about. C represents the concentration of the contaminant in a given medium, such as soil and water. The number used as the media concentration is the EPC. IR is the intake rate. For example, the amount of soil someone swallows or the amount of water someone drinks based on their age. EF is the exposure factor and is derived from how often and how long someone interacts with a contaminant in the environment. This is often based on an exposure scenario we've identified for a site. For instance, this could be the number of days kids attend school or how long a family drank contaminated water from their private well. Finally, BW is the age-specific body weight. ATSDR groups children into 6 different age groups based on body weight and other age-specific parameters, such as water and soil intake rates. These age-specific parameters are important in deriving age-specific exposure doses. I also want to mention that some dose equations, such as for dermal exposures, include additional input parameters than those shown in this general dose equation. If possible, use site-specific exposure parameters in your evaluation. These can be found by talking to people in the community or gathering information from site reports. For instance, your site may be a daycare center, like in the GLC example we've been using. So you would have a site-specific scenario for both the children in the daycare as well as the teachers who work there. FAST has several default scenarios to choose from, such as residential, daycare, schools, and occupational. Also, if you have site-specific information, you can use FAST to come up with your own site-specific scenarios. If site-specific information is not available, You can use default values and scenarios in FAST. The values for default scenarios are already loaded into FAST, so all you need to do is choose a default scenario. You don't have to input them yourself. The primary source that FAST uses for these default factors is EPA's Exposure Factors Handbook. The front cover of the handbook is shown here. ATSDR staff developed various EDG documents to standardize the intake parameters used to estimate exposure doses for ATSDR's standard and special age groups. On FAST resource page, you will find EDGs for body weight, water intake, and soil intake, just to name a few. Other EDGs capture information about life expectancy, exposure factors, and dermal uptake. I encourage you to read these documents if you'd like a better understanding of how media-specific doses are calculated. Now we will talk in detail about exposure factors, also called EFs. EFs consider the frequency and duration of exposure. An EF can be used to adjust the dose or concentration from an intermittent exposure to a continuous exposure dose or concentration. As shown, the EF equation multiplies the frequency, or F, and duration of exposure, or ED, and divides it by the averaging time, which is shown here as AT. Averaging time reflects daily exposure for the duration of exposure for non-cancer endpoints, or it can reflect lifetime exposure for cancer. Default EF in FAST for non-cancer and cancer exposure is 1, indicating that daily exposure is occurring for the entire period of exposure. However, for some scenarios, site-specific information may result in an EF of less than 1, such as if there was intermittent exposure. Once you input the appropriate values for frequency and exposure dose, such as days per week or weeks per year, FAST will calculate the EF for you. I do want to mention that ATSDR's EDG for determining life expectancy and exposure factor, which is housed on the FAGM and FAST resources page, will provide a lot more information than we will have time to cover during this webinar. I encourage you to look at that EDG if you'd like more information. Let's look at an example of where the EF is not 1. Let's assume that children are exposed to soil at a daycare playground 5 days per week, year-round for 5 years. We assume that these children will be going every week during the year, but they will only be there for 5 days of the week. This slide shows the formula where EF equals the F times ED divided by AT. As shown, the parameters include an F of 5 days per week, an ED of 52.14 weeks per year times 5 years, and an AT of 7 days per week times 52.14 weeks per year times 5 years. Therefore, the EF in this example reduces to a 5-day over 7-day adjustment, which equals an EF of 0.714. For inhalation exposure, the air concentration may be adjusted in a similar way. As indicated earlier, exposure doses are not derived for inhalation exposure. While site exposures are continuous, air concentrations are compared directly to inhalation health guidelines. However, when site exposures are non-continuous, air concentrations usually need to be adjusted to a continuous air concentration using frequency, time, and duration of exposure to allow comparison to health guidelines. As shown in the formula on this slide, adjusted air concentration, or AAC, equals C times EF, where the AAC is the EF adjusted air concentration, the C is the contaminant concentration, and the EF is the exposure factors. Let's do an example together. where we calculate an adjusted EF for children exposed to an air contaminant at school, assuming exposure for 8.5 hours per day, 5 days per week, for 36 weeks per year. Using the EF formula, the adjustment results in an EF of 0.25. Calculating the EF is easy and fast. Whether you are using the default parameters or even adding site-specific parameters like in this example, because FAST does the EF calculation for you. For non-cancer scenarios, the time of exposure is averaged over the exposure duration in days, weeks, or years. The default non-cancer scenarios, the EF is 1. This reflects that the frequency and exposure duration are the same in the numerator and denominator and cancel each other out, resulting in an EF of 1. For cancer, the averaging time in the denominator reflects a lifetime exposure of 78 years. For example, as shown in the equation on this slide, the 7 days per week and 52.14 weeks per year are the same in the numerator and denominator, but the 33 years in the numerator is divided by the 78 years in the denominator. This equals an EF for cancer for the default RME of 0.423 for a 33-year exposure duration. The 33 years assumes exposure for 21 years as a child and 12 years as an adult, or for 33 years as an adult. Again, FAST will calculate this for you. You can also use FAST to examine dermal exposure from contact with soil and sediment and from swimming in surface water. FAST derives a dermal exposure dose using dermal exposure factors such as skin surface area and dermal permeability. The dermal dose is then adjusted by the fraction absorbed through the gastrointestinal tract to allow it to be compared to oral health guidelines. Please refer to the soil sediment dermal EDG and the surface water ingestion and dermal EDG for further information on the exposure parameters used in the dermal pathways. They are in the resource section of FAST and FAGM. ATSDR can also evaluate dermal and inhalation exposure from household water use using ATSDR's showering and household water use exposure model. We call this the shower model. Let's talk a bit about that model now. ATSDR's shower model evaluates inhalation and dermal exposure from household water use, primarily from showering. The model uses a default 4-person household scenario, but you can modify the model for up to an 8-person household. You can also modify it for various household setups, including number of bathrooms, use of a bathroom fan, and whether people are home or away from the home part of the day. The model provides a daily exposure concentration and dermal dose associated with the most highly exposed person in the household that can be further evaluated in FAST. I also want to mention that there are ways to integrate the shower model data into FAST by using the shower model exposure calculator in FAST. We won't have time to go into this today, but I encourage you to check out ATSDR's training videos related to the shower model on CDC's YouTube page. Please go to www.youtube.com and search for ATSDR shower and household water use exposure to find the 3rd version of the shower model. Search as well for shower model exposure calculator to find the FAST shower model webinar. There are also details on the shower model in the resources section of FAST and FAGM, along with links to the training videos. After you have your exposure doses or air concentrations, the next step is a comparison to the appropriate health guidelines to derive non-cancer HQs and to use cancer risk values to calculate cancer risk. Health guidelines for non-cancer endpoints include MRLs, which are developed by ATSDR. They can be for chronic, intermediate, or acute exposure durations, depending upon the available toxicological data. MRLs are only for non-cancer. ATSDR does not derive health guidelines for cancer. For non-cancer evaluations, EPA provides chronic health guidelines that include RFDs for oral exposure and RFCs for inhalation exposure. For cancer risk, EPA develops CSFs for oral exposure and IURs for inhalation exposure. Sometimes health assessors may use health guidelines from other sources, such as values from California EPA. However, to ensure it is appropriate, you should always consult a subject matter expert, or SME, at ATSDR prior to using any health guideline from a source other than ATSDR or EPA's Integrated Risk Information System, or IRIS. Now let's test your knowledge about what we've learned so far. From the list presented, which do you think are not values developed by ATSDR? There could be more than one correct answer. Possible answers include A, chronic MRL, B, cancer slope factor, C, intermediate MRL, D, reference concentration, and E, acute MRL. I'll pause for a moment to let you think about those on your own. Okay, so how did you do? The correct answers are B, cancer slope factor, and D, reference concentrations. These are values developed by EPA rather than ATSDR. So now that we've discussed what an exposure dose is and what health guidelines are, let's talk about how we use that information to calculate HQs. HQs are calculated to evaluate non-cancer hazards for contaminants with available non-cancer health guidelines for appropriate durations of exposure, which include chronic, intermediate, and acute. The equations are presented on the right side of this slide. The oral and dermal HQ is calculated by taking the dose and dividing it by the oral MRL or RFD. The inhalation HQ is derived by taking the EF adjusted air concentration and dividing it by the inhalation MRL or RFC. FAST will calculate the oral, dermal, and inhalation HQs for you. For carcinogens, we use a similar process. The cancer risk is calculated for those contaminants with available cancer risk values. Again, the cancer risk values are only used to evaluate chronic exposure and are only available from EPA as oral slope factors or inhalation unit risks. For oral and dermal exposure, the daily exposure dose is multiplied by the CSF and adjusted for exposure duration over a lifetime. Remember that for cancer, the dose is adjusted for lifetime exposure. So the exposure duration, for example, 33 years, is divided by a lifetime of 78 years. For inhalation exposure, the air concentration is multiplied by the IUR and adjusted for exposure duration over a lifetime. FAST will make the appropriate adjustment for you when calculating cancer risk. So now you have the HQ and cancer risk derived for you, but what do you do with them? That's the next part of the process. For non-cancer, you compare the age and duration specific HQs for both oral and inhalation exposure to 1. HQs lower than 1 indicate a non-cancer hazard should not be an issue for exposure to that contaminant for that duration of exposure. If an HQ is greater than 1, health assessors will retain the contaminant for further toxicological evaluation. Similarly, for evaluating cancer, the calculated cancer risk is compared to a risk of 1 times 10 to the minus 6, which reflects an excess cancer risk of 1 in a million. This is the cancer risk that is in addition to the baseline cancer risk that we all have. Those contaminants with cancer risk equal to or above 1 times 10 to the minus 6 are retained for further toxicological evaluation. Okay, let's do another knowledge check. Which of the following will not be calculated by FAST? There can be more than one answer. The options are A, inhalation exposure doses, B, oral hazard quotients, C, inhalation cancer risks, D, oral exposure doses, and E, inhalation hazard quotients. I'll pause to give you a moment to think about the answer. Okay, well, how did you do? The correct answer is A, inhalation exposure doses. As we discussed earlier, FAST does not calculate doses for inhalation exposure. All right, now let's talk about next steps. As I indicated, a further toxicological evaluation should be done when an HQ is greater than 1, a cancer risk is greater than 1 times 10 to the minus 6, when health guidelines are not available for a contaminant, or when the contaminant is a community concern. The toxicological evaluation webinar in this training series covers this topic. We're going to take a look at a couple of examples from the GLC site. First, we will examine oral exposure to arsenic in soil for children and teachers at the daycare center. Then we'll talk about exposure of residents and one of their guests to carbon tetrachloride in the drinking water at a home located down gradient of the GLC site. The scenario for the daycare center includes teachers and children exposed to arsenic in the soil around the daycare facility. Children are present the entire year, and teachers have a 2-week vacation period. Both groups are present 5 days a week. An EPC was derived based on soil samples taken in the yard of the daycare center. The scenario for the drinking water is a family being exposed to carbon tetrachloride through their drinking water. The home, referred to as PW3 here and in the online FAT training, gets its drinking water from a private well. The family has an adult house guest who stayed with them on Fridays, Saturdays, and Sundays over a consecutive 5-week period. 10 water samples were taken at the private well location at PW3, so an average concentration could be identified for exposure. For the arsenic and soil scenario, arsenic values will be put into FAST. A maximum of 1,020 parts per million, or ppm, will be used for screening, and an EPC of 545.1 ppm, the 95th UCL of the mean, will be used for deriving an exposure dose. EFs are derived for both groups. The child who is in daycare year-round and the teacher who takes 2 weeks of vacation each year. Both groups are there for 5 days a week, but the children are there 52.14 weeks per year, and the teachers are there 50 weeks per year. The value of 52.14 reflects 365 days divided by 7 days per week. This concludes my part of the presentation. Next, Michelle Arbogast will demonstrate how to run this scenario using the FAST application and will continue with this presentation.
My name is Michelle Arbogast. I'm a senior environmental scientist at Eastern Research Group, known as ERG, and a contractor to ATSDR. I have been supporting ATSDR with public health assessments for almost 25 years and have been involved with developing FAST since 2016. Today, I will show you how to use the FAST application to run the arsenic in soil scenario previously explained in this presentation. Here is what the FAST main page looks like. You can import your site information and data by clicking on the Site Information and Data box. From this pop-up box, I will choose Site Data so I can show you the data import screen. On the Site Data screen, I want to show you the data import template. I can click on the Here on this page to download the template. Then the FAST template, which is an Excel file, downloads onto my computer. I click on the download icon to open my downloads folder, and then double click on the file to open it. The template includes the following fields that you can populate to upload into FAST: contaminant, CAS-RN, media, maximum concentration, maximum unit, EPC, EPC unit, and EPC type. If you choose to screen your data, FAST will automatically use the maximum concentrations. If you choose to calculate doses or adjusted air concentrations, FAST will automatically use the EPCs. Now, back in FAST, I'll go back to the home page and mention that you can save your results and then find them in the My Saved Results module. If you want to screen information, you can click on the CV screen box. And here's your exposure calculator. I do want to take a look at the CVs and health guidelines module, so I will click on the link to go there now. As Karen said, all of ATSDR CVs, the ATSDR and EPA health guidelines, and EPA cancer risk values are stored here. Let's take a look at arsenics, since this is the contaminant we're going to be evaluating in the daycare soil scenario. In the contaminant CAS-RN box on the left, I will type in the word arsenic. The search results appear showing all the chemical names in the FAST database that contain the word arsenic. So I will click on the arsenic to select that from the drop-down list. Then I'll click the View Contaminant Information button. As I scroll down, the non-cancer health guidelines are presented for arsenic. We're going to be looking at chronic for oral and dermal exposure to arsenic in the soil. We have an MRL of 0.0003, and there is an RFD that is the same value. We don't have an intermediate MRL, but we do have an acute MRL of 0.005 milligram per kilogram per day. As I scroll down, for cancer risk, we have an oral slope factor of 1.5 per milligram per kilogram per day to the -1, and cancer classifications from various agencies. This section will also tell you if a contaminant is a mutagen. As this indicates, arsenic is not. When we do have a mutagen, FAST will apply age-dependent adjustment factors, or ADAFs, when estimating cancer risk. I just wanted to point out that this information about being a mutagen and applying ADFs is located on this part of the page. Also, as we scroll down, there may be further toxicological information listed for the contaminant, which is arsenic in our case. I'll scroll through to show you the oral health guideline information section. As I keep scrolling, we learn this is followed by the inhalation guideline information section. We don't have any inhalation MRLs or an RFC for arsenic, but as we keep scrolling, we get to the carcinogenic risk information. At the bottom of this screen is additional information about cancer, such as the tumor types, species, and extrapolation methods. So then we will scroll up and click on the Soil CVs tab, as we're going to be examining the soil CVs. As shown here, there are child and adult comparison values. We have a cancer risk evaluation guide, also known as the CREG, because it is carcinogenic. And we have chronic environmental media evaluation guides, also known as EMEGs, which are based on the chronic MRL, and reference dose media evaluation guides, also known as RMEGs, which are based on the RFD. The EMEGs and RMEGs are the same because the MRL and RFD are the same. Again, there's no intermediate EMEG because we don't have an intermediate MRL, but we do have acute EMEGs because we have an acute MRL. So we're looking at this and learn the recommended ATSDR-CV is the highlighted value with the asterisks. The recommended ATSDR-CV is normally the lowest value, which would be the Craig here. For arsenic, however, it is not the Craig because the arsenic Craig of 0.26 ppm is below natural background of 5 ppm. So we recommend that the child EMEG and RMEG, the value of 16 ppm, is used to screen arsenic. Also, let's look down at the pica section, which is an issue for ingestion of arsenic in a daycare scenario. We do have an acute EMEG of 27 ppm for children with soil pica. Now, when you have a scenario for children or teachers exposed from ingesting soil, they are typically exposed when they go outside, especially the children. When children play in the dirt, they get it on their hands and then put their hands in their mouth, which can result in transferring soil contaminants into their bodies. They can also ingest soil and dust brought into the daycare center from outside. But for children with pica who actually eat the dirt, it can obviously be a dangerous practice if there is any contaminated soil. So for certain contaminants, we look at pica in the soil to protect these children. Okay, let's scroll back up and click on the Resources tab so we can navigate to that module. This has everything you may want to know about FAST. There are various FAST resources, such as the user's guide, default parameters, vapor intrusion, and training videos. It also provides information on the shower model, such as a user's guide and a technical document, as well as contaminant-specific guidance and resources. So the resource I am pointing to now is where you will find recommendations for the default value for the relative bioavailability of arsenic in soil. And we're going to look at that when we go through this arsenic scenario. There are also specific guidance and requirements for hexavalent chromium and dioxin. And we have also put together several informational resources for PFAS, as well as individual resources for TCE. And we have these EDG documents, such as for body weight, water ingestion, and surface water ingestion and dermal contact. These EDG documents provide the methods and default intake factors programmed into FAST that we use to estimate exposures from different pathways. We have links to ATSDR's tox profiles and the toxic substances portal, a link to the web-based FAGM, and just all kinds of useful information. We also have this section on vapor intrusion. I do want to mention that ATSDR updates the resources on this FAST page regularly. So what I'm showing you now could be removed, updated, or replaced with new guidance in the future. Just something to keep in mind as we are taking a quick peek on what's on the FAST resources page as of now. If you don't find the information you're looking for on the FAST resources page, then just ask the ADS office or your technical project officer if you're with a state health department, and we'll try to find what you need. But this really is a pretty comprehensive resource list for health assessors. Now I'll go back to the FAST homepage. Now what I'm going to do for arsenic is to start with a screen. Even though we know that the CVs are exceeded, I will go to the CV screen module and choose the soil/sediment from the drop-down menu. Under the Choose Contaminant section, we're going to type in arsenic, select arsenic from the drop-down list, and enter the maximum concentration of 1020. In the unit drop-down, I will choose ppm for our scenario. When choosing your unit, you should pick whatever you have in your dataset because FAST will convert it to the appropriate unit to screen and to calculate doses. You can also add more contaminants by choosing the Add Another Contaminant button. After we click the Compare button, the results table appears. This is what the comparison to CVs looks like. Does it exceed the recommended CV? The red shaded cell that I am hovering over with the yes in the above or equal to recommended ATSDR CV column indicates that yes, it does. Does it exceed other CVs? It does, which we can tell from the yellow shaded cell that I'm hovering over in the above or equal to other CV column. And this blue flag that I'm pointing to on the left has text explaining that the Craig for arsenic is below the soil background level, which is why the Craig is not the recommended CV. The recommended soil CV is the chronic EMEG and RMEG, which are both 16 ppm. Thus, the concentration of 1020 ppm exceeded 16 ppm, which means we will select arsenic for further evaluation as a potential contaminant of concern. Again, if you had 10 contaminants, whatever the results of the screening would be presented in this table shown on the screen. Below the results table is the Select Contaminants for Further Evaluation table. This presents various information such as the maximum concentration, the ATSDR recommended CV, and the CV type. When multiple chemicals are present, the column header can be sorted. The table also indicates with a yes or no if the contaminant should be selected for further evaluation. When the recommended CV is exceeded, it automatically checks the box I'm pointing to select the contaminant for the exposure calculator. And again, this could be something where you had a contaminant that a community was really interested in. It may not have met or exceeded the CV, but we could check this box if we want to run it through the FAST exposure calculator and show the community that it is not an issue. Now we'll click on the Continue to Exposure Calculator button and click Leave, acknowledging that we are leaving the CV screen module. Notice that we've moved from the CV screen module to the exposure calculator module. It shows arsenic and my maximum concentration already included. The value that I'll type in now is the EPC, which we previously determined is 545.1, and I will pick the unit of ppm and choose 95% UCL of the mean for the EPC type. Next, we need to decide whether the Run Quick Summary or enter site-specific parameters. If we pick Run Quick Summary, FAST will generate results for a residential scenario. But this is a daycare scenario, so we need to click Enter Site-Specific Parameters so that we can enter site-specific parameters for a daycare. The next screen is for exposure groups and body weights, and it shows you that there are residential, trespasser recreational, daycare, school, occupational, and other scenarios. We are working on a daycare scenario, so I will check that radio button. You'll need to decide what age groups to include in your scenario and whether there are full-time, part-time, or both types of workers present. In this case, I know that the daycare only allows 1 to 5-year-olds onto the playground. Thus, for my exposure groups, I will select the 1 to 2-year-old and 2 to less than 6-year-olds. We also want to look at full-time and part-time workers, so I'll check those 2 boxes. Next, we will click the Enter Exposure Factors button to go to the next screen. Now we will look at our exposure factors. We do have exposures of more than a year, so we're going to keep the button selected for chronic, intermediate, and acute scenarios. We now need to decide the exposure factors by selecting the appropriate radio button underneath exposure options. If you want to use all default exposure factors for your scenario, select the middle radio button. It will use default CTE and RME values for days per week, weeks per year, and exposure duration. If you want to use site-specific exposure factors for your scenario, select the first or third radio button. The first radio button is for using site-specific exposure factors and site-specific exposure durations. CTE and RME results will not be calculated. Use this radio button if you have, for example, a child who goes to daycare only 3 days a week, or you have a 4 days a week school. The third radio button is for using default CTE and RME values for days per week and weeks per year, but a site-specific exposure duration. For this daycare scenario, we're selecting the second radio button in the middle because we want to use all default settings. You'll notice that when I select the middle radio button, the boxes in the columns labeled site-specific turn gray, which means they are inactive. Here, let me do this again. I will now click on the box to enter intake rates to go to the next page. Okay, now let's talk about the soil intake rates for children and adults at the daycare. You can check to use default CTE and RME intake rates box and use the default values, or you can enter something site-specific if you have that for your site. If you look at the soil intake rates, you can tell that there are CTE as well as RME intake rates. CTE is more the average, so it ranges from 60 to 90 milligrams soil ingested per day, depending upon the child's age. The high exposure end is the RME, which is 200 milligrams soil ingested per day for the children in our scenario. If you look at pica, you can tell that it's much higher than the non-pica soil intake rate. So we are examining pica, but it will be its own evaluation. We have the 1 to less than 2-year-old and the 2 to less than 6-year-olds. For arsenic, as mentioned before, there is a default oral relative bioavailability factor that is 60%. This is specific to arsenic. We have it here on this page in FAST so that you know FAST is using it. You don't have to do anything with it. FAST includes it automatically when arsenic is the contaminant. Now let's click the Enter Adherence Factors button so we can look at some factors for the dermal pathway. The adherence factor is basically how much the soil adheres to the skin. We're going to check the Use Default Adherence Factors box to use the default adherence values, which are 0.2 for children and 0.07 for adults. Then we will click the Enter Skin Surface Areas button to go to the next page and look at the skin surface areas for different age groups. For this scenario, we will use and check the box Default Skin Surface Areas for each body part. We are assuming that a child has short sleeves, shorts on, and wears sandals. So we are evaluating that the skin available to be exposed is on their head, hands, forearms, lower legs, and feet. And it's the same for each age group. We will look at all those different body parts, and then this combined skin surface area is what we end up using in the FAST module. We'll use the same body parts for adults. Now let's click the Calculate Results button. After the results screen loads, you'll see the chronic, intermediate, and acute tables showing the combined results from ingestion and dermal exposures. We recommend that you use the results from the combined exposures. If you scroll down, you'll see tables for ingestion only and dermal only. These tables are provided for information purposes and are typically not included in public health documents. Before we look at the results, I want to show you how to find the parameters that went into calculating the doses shown in the results table. I will click on the Show Input Parameters button on the top right to display the table on the screen. This provides information that this scenario is for arsenic, has your EPC, and the dermal factors. Again, you can go into the EDGs and look for exactly what they are, but there's a dermal absorption fraction, a gastrointestinal or GI absorption factor, and the 0.6 bioavailability factor for soil. It shows the equation for soil ingestion, which I'm pointing to here, and the equation for the dermal dose. Below the dermal dose equations are your body weights, your intake rates. Again, there's the 5,000 milligram intake rate for children with soil pica behavior, adherence factors, and the combined skin surface area. FAST also calculates your exposure factors in this table. For instance, for intermediate and chronic RME, we have an EF of 0.71 for the 5 days a week. Then for pica, which we consider with acute or intermediate soil scenarios, we have an EF of 0.43, since it's 3 out of 7 days. Now I'll scroll up back to the combined results table for chronic exposure. And I will say this is a little complicated. This example shows that we have a site-specific scenario, which is on the left side of the results table. Here, we're only looking at 2 of the 3 child age intervals. FAST also provides you the whole default scenario on the right side of the table. So you can do a reality check. If, say, your RME hazard quotient was 300 over on the default side, and here on the site-specific side it was 2, well, you would know that's a huge disparity. You would want to go back and make sure that what you're inputting is really what you wanted to input and is appropriate. But here these values seem appropriate. You'll remember the combined table is showing the values from both oral ingestion and dermal uptake. There are 2 ways to find out how much each pathway contributes to the combined results. In the combined results table, you can click on the dose, hazard quotient, or cancer risk values to see the contribution from each pathway. Here, I'll click on a dose now to show you an example. A formula appears that shows how much of the combined dose comes from oral ingestion and how much comes from dermal uptake. When you're ready, you can click on the Download Results button and choose the 508 compliant option to get a nice 508 compliant table to put into your document. This file downloads just like the data import template. Now I will go back to the PowerPoint presentation. This is the 508 compliant table that FAST outputs for you, with the version on this slide showing the part for children. We will talk about adults in a bit. This is the combined ingestion and dermal doses for the chronic exposure scenario, and it shows the 2 age groups we are evaluating. The hazard quotients for the RME, the 15 for 1 to less than 2-year-olds, and the 10 for 2 to less than 6-year-olds are shown. And the total child RME cancer risk for the 2 groups is 3.2 to the -4. Now I am presenting the results table for the 2 child age groups for the intermediate scenario. Because we do not have an intermediate MRL, FAST could not provide an HQ. And again, cancer risk is only calculated for chronic exposure, so cancer risk is not included in this intermediate results table. This table shows the results for the 2 child groups for the acute exposure scenario. We have an acute MRL, so we do have acute non-cancer hazard quotients for CTE, RME, and soil pica, and these are based on using that 545.1 ppm concentration. I will now go back to FAST to show you something for pica. You'll notice that children with soil pica behavior have an acute HQ ranging from 8.2 to 12. These HQs are based on children having soil pica behavior 3 times a week. As those children are eating the dirt, we do assume that they are sitting there and eating it in one spot. This means we are going to assume that they may be exposed to the maximum concentration of arsenic in soil. So let's go back to the contaminant information page and replace the 545.1 value with the maximum concentration of 1020. I will keep ppm as the unit. I will change the EPC type in the dropdown to maximum. I will click the Enter Site-Specific Parameters, and most of this will be the same. Then I will click the Enter Exposure Factors button to go to that page. Notice the 3 days a week for a child exhibiting pica behavior. These should all be the same. Then I will click on the Enter Intake Rates button, and these are all the same. Then I will click on the Enter Adherence Factors button and confirm that these are all the same. I click on the Enter Skin Surface Areas button and note that these are all the same. And then I click Calculate Results. And now I'll go back to my PowerPoint presentation. We can take a look at the acute ingestion and dermal per child for pica, and that shows we do have much higher soil pica hazard quotients. We have an HQ of 23 for the 1 to less than 2 years group and 15 for the 2 to less than 6 years group. You should remember these acute doses and hazard quotients for children with soil pica behavior when you do your toxicological evaluation to see if they are at risk of serious health effects just from eating dirt from the most contaminated part of the daycare yard. This table presents the chronic, intermediate, and acute RME HQs, as well as the acute pica HQ for children at the daycare center. As shown in this table, there is a chronic HQ that exceeds 1 for both groups of children. The acute HQ exceeds 1 for the younger child. And when we look at the acute pica using the 1020 ppm maximum soil concentration, we find there is an issue with the pica child as well. The cancer risk of 3 times 10 to the minus 4 is well above the 1 times 10 to the minus 6 screening level. So, if we examine the input parameters for the adult, full-time, and part-time daycare workers presented in this FAST table, we can tell that they're basically the same. We have a body weight of 80.6 kilograms and intake rates of 30 milligrams per day for CTE and 100 milligrams per day for RME. Their exposure factors are 1 for CTE and RME acute, 0.71 for CTE and RME intermediate, 0.68 for CTE chronic, and 0.71 for RME chronic. Now let's look at the combined soil exposure for workers from ingesting and coming into contact with arsenic-contaminated soil and dust. First, let's look at the chronic exposure results table for daycare workers. We find that there is an RME hazard quotient for the full-time worker of 1.2. That's just above 1. And the RME cancer risk for full-time workers is 1.4 times 10 to the minus 4. We also have CTE results for full-time daycare workers. The CTE HQ is below 1, and the CTE cancer risk is 1.5 times 10 to the minus 5. I want to point out that for part-time workers, FAST only provides CTE results because we could not find reliable estimates for RME exposure parameters for part-time workers. On this slide, we have the results table for the intermediate exposure for daycare workers. Again, there is no hazard quotient calculated for intermediate exposure because there is no MRL. This table shows the results for acute exposure for daycare workers. And for acute, it looks like we have CTE and RME HQs that are well below 1. Now we have a summary table with the results of the GLC evaluation for arsenic in soil for full-time and part-time daycare workers. The chronic CTE HQ for both full-time and part-time workers is below 1. and the chronic RME HQ for full-time workers is just above 1. Again, we are not able to calculate intermediate HQs because there is no MRL for intermediate exposures. The acute CTE and RME HQs are below 1. And finally, for cancer, we have estimated cancer risks for full-time workers that range from 1.5 times 10 to the minus 5 to 1.4 times 10 to the minus 4 for workers with CTE and RME exposures, respectively. The cancer risk for part-time workers is 9.2 times 10 to the minus 6. So now we will move on to the example from the GLC site that examined carbon tetrachloride exposure from use of a private well. You'll remember that this household included a weekend house guest. This slide shows the parameters that will go into our calculations. Let's talk through them. We're going to use our EPC of 262.7 ppb. The residents are exposed year-round at their homes, so we will use an exposure duration for the residents that considers daily exposure for 33 years. The exposure duration for the house guest is 3 days a week for 5 weeks. Our calculated exposure factor for the residents is 1, which is for daily exposure. The calculated exposure factor for the house guest is based on 3 out of 7 days a week over a period of 5 weeks, and we end up with 0.43 as our exposure factor for the house guest. This is the input parameters table for water ingestion for the residents. For the intake factors, we are examining residents of all ages. We are considering each exposure group's specific body weight, exposure duration, and CTE and RME water intake rates. We have an exposure factor of 1 for the chronic residential exposure. The chronic results for the ingestion of drinking water for residents is shown in this table from FAST. We do have CTE and RME hazard quotients that exceed 1 for most of our exposure groups. The highest RME HQ is 9.4 for the birth to less than 1 year age group, and that's understandable. That age group represents an infant whose diet is primarily liquid consisting of formula made using tap water. We do have a high cancer risk ranging from 8.7 times 10 to the minus 5 for CTE exposure and 2.4 times 10 to the minus 4 for RME exposure. This table I'm presenting now shows the intermediate results from FAST for the house guest ingesting drinking water. We do have an intermediate MRL for carbon tetrachloride, so we are able to calculate an intermediate hazard quotient. And again, that birth to less than 1 year infant has the highest HQ, which is 5.4 for the RME. This table shows the acute results for ingestion of drinking water from FAST. Similar to intermediate, the birth to less than 1 year infant has the highest hazard quotient, which is 1.9 for the RME. The CTE and RME HQ for the other age groups, including adults, are 1 and lower. This slide presents a summary of the results for the GLC evaluation for residents ingesting carbon tetrachloride in drinking water. As shown, the HQ of 1 is exceeded for the infant with all 3 durations. Specifically, the HQ for the infant are 9.4 for chronic, 5.4 for intermediate, and 1.9 for acute. And the cancer risks for children and adults are 2 to 3 times 10 to the minus 4. Now, let's examine this FAST input parameters table for the house guest for drinking water. This table indicates the guest is an adult who is at the house for 3 days over 5 weeks. This results in an exposure factor of 0.43. This slide has the FAST results for the house guest who drank the water for 5 weeks. It shows an RME hazard quotient of 0.62. The guest is not at the house for very long, and this is an intermediate exposure. We did not calculate chronic results for the house guest because we did not have a chronic exposure. It was only a 5-week exposure, so we calculated only acute and intermediate HQs. This table shows the FAST acute results for the house guest. The results show an acute RME HQ of 0.51. This slide shows the results of the GLC evaluation for the house guest from ingesting carbon tetrachloride in drinking water. The HQs for acute and intermediate exposures are below 1, so there's no concern for non-cancer effects. There is no chronic exposure, so no cancer risk is calculated. We only calculate cancer risk for chronic exposure. Well, we have certainly gone through a lot of information in this webinar. As a quick recap, we talked about how to evaluate the contaminants that met and exceeded CVs from Module 6, calculate exposure doses for ingestion and dermal contact, derive HQs to evaluate non-cancer hazards, calculate cancer risk for carcinogenic contaminants, evaluate exposure to contaminants in air, and use FAST to evaluate default and site-specific exposure scenarios. And that concludes the Performing Exposure Calculations webinar. Thank you so much for watching.